السلام عليكم ورحمة الله وبركاته. طلاب المرحلة الثالثة, we will continue with our approach to patient symptom. Here we discuss approach to patient with jaundice. What is jaundice? Jaundice or icterus is a yellowish discoloration of the sclera, skin and mucous membrane resulting from the deposition of bilirubin. So first thing we need to know is that we put sclera first because bilirubin has high affinity for elastin, which is presented in high concentration in the sclera. So in patient with jaundice, the first part in his body to be involved and become yellowish is the sclera, then spread to the skin and the mucous membrane. This is number one. Number two, bilirubin is normally presented in our body, but only when it's present in a quantity more than normal, when that cannot be handled by the liver, it will deposit in the tissue and causing yellowish discoloration. So tissue deposition of bilirubin occur only in the presence of hyperbilirubinemia. Normal serum bilirubin is about 0.3 to 1 milligram per deciliter. This is an example of patient with jaundice, and we see the sclera is yellow in color. So first thing is first, we need to know some physiological points about bilirubin, how bilirubin develop in the body. So about 4 milligram per kg per day of bilirubin normally turn over each day. So this is a large amount of bilirubin in the body. About 80 to 85% or more than 75% of this amount resulting from the breakdown of hemoglobin in the RBC during normal red cell turnover. The remaining amount, which is about 15 to 20, result from turnover of hemoprotein presented in other tissue, mainly skeletal muscle, in the form of myoglobin. So when RBC turnover, when the lifespan of RBC reach more than 120 days, it will be destroyed in the reticuloendothelial system, which resulting in release of hemoglobin. As its name applies, hemoglobin consists of two parts: heme, which is the iron containing part, and protein, globin. So there is the heme. Other part in the body that can result in heme is ineffective erythropoiesis, when there is destruction of RBC within the bone marrow, or by breakdown of heme containing tissue, mainly skeletal muscle, as we say in myoglobin. All will result in the production of heme. By the effect of heme oxidase enzyme in the reticular endothelial system, heme will be converted into biliverdin, which further reduced by enzyme biliverdin reductase to produce bilirubin. This bilirubin is unconjugated, still till now within the reticuloendothelial system. It is water insoluble and cannot be transported in the blood. So in order to facilitate its transport, it will bound to protein albumin as a carrier molecule, and it will be transported to the liver. Within the liver, there will be cleavage of albumin, and bilirubin, which is unconjugated, will be enter the liver cell or hepatocyte. Within the cell of the liver, by the effect of enzyme glucuronidase transferase, the unconjugated bilirubin will convert it into conjugated type, which is water soluble. This bilirubin will conjugate it with glucuronic acid to form either bilirubin monoglucuronide or bilirubin diglucuronide, a conjugation process that catalyzed by enzyme called bilirubin uridine diphosphate glucuronyl transferase or UDBGT. After the conjugated bilirubin form, it will be transported into the canalicular membrane to be excreted into the biliary system. The main hepatic duct will join the gallbladder cystic duct to form common bile duct that will be open in the second part of the duodenum, and all conjugated bilirubin will be excreted into the duodenum. You need to know the conjugated bilirubin is an absorbable substance, so it will be travel along the intestine. It will have one of two processes. By the effect of enzyme glucuronidase, the conjugated bilirubin will cleave and return back to its unconjugated bilirubin. This can be absorbed from the intestine and will return to the blood, where it's returned again to the liver, and this circle will continue and is called bowel hepatic cycling. Enterohepatic cycling. This amount of bilirubin represents about 10 to 20% of the total secreted bilirubin. The remaining part will be acted on by certain type of bacteria within the bowel to form either stercobilinogen, which is secreted with feces and responsible for the color of the feces, or urobilinogen, which is absorbed and secreted with urine and responsible for the color of urine. These amounts responsible for about 80 to 85% of the secreted bile each day. So, when a patient presented to us with a complaint of jaundice, how we approach such patients? In the evaluation of patients with jaundice, we need first a focused history, and we talk about history in detail, then do physical examination. After that, we have to proceed with lab investigation to determine what is the type of the jaundice the patient has. So first is history. What about history? First thing we need to focus on is the onset of history. Is it acute within days, which could occur in patients with gallstone obstructing the gallbladder, or inflammation of the gallbladder? Is it inflammation of the liver itself in acute hepatitis, or obstruction of the venous outflow of the liver in Budd-Chiari, or could be hemolysis? These occur within days, so it is acute onset. Could be subacute within weeks or months, usually, but not always, malignant process, pancreatic hepatobiliary, or cholestatic process, or maybe in patient with right side heart failure and congestion, venous congestion of the heart will result in congested liver. Is it recurrent episode of jaundice the patient has, in which there is a time interval he will become normal, such as recurrent gallstone, or an inherited disorder where jaundice occurs in a specific situation, like in Gilbert syndrome? What is the associated symptom with jaundice? Is there any abdominal pain, mainly right upper quadrant pain over the liver, which could indicate infection, inflammation, or collection? Is there any nausea, vomiting, anorexia? Is there any weight loss, which could indicate underlying malignancy? Is the color of stool pale or clay color, meaning there is no secretion of bile into the stool, which indicate obstructive jaundice? There is obstruction, there is no secretion. dark of urine is important. If there is itching, which means there is cholestatic process within the liver, there is bleeding, you need to know that the majority of blood clotting factor is produced in the liver, so where there is problem with liver, there may be bleeding, fever, which may indicate underlying infection, confusion, which may indicate body overload with ammonia due to poor process by the liver and will cause hepatic encephalopathy. Other parts that is important in history include if the patient has a previous history of needle stick, surgery, blood exposure, which could indicate previous infection with mainly hepatitis B or C. If there is any history of gallbladder disease or gallstone previously, if there is any history of hemolytic disease, and there is overproduction of bilirubin from blood hemolysis, there is exposure to patient with jaundice, again with infection, family history of jaundice, which could indicate either infection or inherited disease of the liver. If there is any medication use, there are a lot of medication that can cause jaundice. The two most common drugs that resulting in liver disease or jaundice including acetaminophen or paracetamol, and another drug is antibiotics, which mainly co-amoxiclav or traditionally known as augmentin. Sexual history is important as both hepatitis B and C are sexual transmitted disease. Travel history again is important as both there are certain parts of the world where some liver disease are endemic, such as hepatitis A in India. Alcohol history is important as alcohol one of the most common cause for chronic liver disease. In patient examination, we should focus first on vital signs: pulse rate, blood pressure, temperature, respiratory rate. The degree of jaundice can be estimated by general examination of the patient, and we could divide it into three types. Patient with mild jaundice, or we say tinge of jaundice or lemon jaundice, which could indicate underlying hemolytic anemia or hemolytic process. While patient with deep yellow jaundice, it may indicate hepatic process. The liver is involved in the process, not hemolytic. In case of obstruction in the biliary system where the secretion of conjugated bilirubin is not complete, the jaundice will become very deep, greenish yellow in color, and the patient had itching and added to jaundice. The presence of pallor or anemia indicate underlying hemolysis. There is an abdominal tenderness, which could point to an area of inflammation or collection. Liver size is important. In chronic liver disease, the liver will be small in size or shrunk liver due to liver fibrosis, as occur in patients with cirrhosis, or in some type of cirrhosis or metabolic disorder, there will be a large liver. While the character of liver is important. Is it smooth, tender, indicate acute process mainly during infection or inflammation, while hard, nodular could indicate underlying malignancies or cirrhosis again. Splenomegaly signify underlying portal hypertension. If there is any sign of liver failure, means synthetic process of the liver will impair, and you need to know the most important parts of liver synthesis, including coagulation factor. So in liver failure there will be bleeding and ecchymosis all over the body, and protein usually mainly produced by the liver. So when there is liver failure, there will be decrease in protein synthesis and decreased total protein, resulting in edema on the body. If there is mental status change, which could indicate hepatic encephalopathy, abdominal swelling with ascites also indicate portal hypertension, as we discussed previously in patients with ascites. So an example, this patient has yellowish discoloration of the sclera, so he has jaundice. This patient has chronic liver disease and have several abdominal signs. First, there is ascites, as we see distended abdomen. Second, the umbilicus is protruded outward, so it is everted due to increased intra-abdominal pressure. Third, there is multiple dilated superficial veins which indicate portal hypertension and portosystemic connection. After history and examination, we proceed with lab investigation. So this patient needs to be sent for complete blood counts to see if there is any anemia, which could indicate hemolytic anemia. If there is elevated in white BC count, which could indicate underlying infection. Platelet count in chronic liver disease will be low, so thrombocytopenia is one of the markers of chronic liver disease. Next, we will go to liver function test. Patient need to do bleeding time, clotting study, PT and INR, all of this to assess the synthetic function of coagulation factor. Serum albumin, when serum albumin low, could indicate chronic process, because only in chronic liver disease there will be impaired protein synthesis by the liver. And final blood culture to indicate underlying infection also needed. Let's take a few points about liver function test. A liver function test, there is serum bilirubin. We need to do serum bilirubin, which is normally 0.2 to 0.8 milligram per deciliter, which is divided into two parts, as we discussed in the physiology: indirect and direct, or unconjugated and conjugated. Indirect mainly 0.1 to 0.3 milligram per deciliter, while the conjugated type constitute about 2.2 to 0.7 milligram per deciliter. There are a lot of enzymes involved in liver disease and important in liver function. These include AST and ALT, or called aminotransferase enzyme, normally 0 to 35. Alkaline phosphatase, which is normally 30 to 120. Total serum protein, synthetic function of the liver, normally 5.5 to 8.5 gram per deciliter, which constitute albumin, that globulin, albumin 3.5 to 5.5, while globulin 2 to 3 gram per deciliter. We talk about the enzymes. So, ALT meaning alanine aminotransferase, to produce within the liver cell mainly, and it is the most sensitive marker for liver damage. Next enzyme is aspartate aminotransferase, or AST, also produced within the hepatic cell, but is less specific than ALT because it can be produced by other cells, mainly cardiac muscles and skeletal muscle. So it could be elevated in patients with myocardial infarction. Finally, alkaline phosphatase, which present or produce in the cell of bone, liver within the hepatobiliary system, and in placenta of a pregnant woman. So not always when alkaline phosphatase it indicates liver disease, because it can presented with bone disease or bone metastasis, and it's also normally elevated during pregnancy by secretion from the placenta. It is secreted from the biliary system, so it is more specific for obstructive jaundice, where there is obstruction in the biliary secretion. So, how to evaluate patient with jaundice? As we previously discussed, we will start with history, physical examination, and lab test. After that, we decide the patient will fall into one of two groups. Either the patient has only bilirubin elevated while all other liver function tests are normal. This patient, we call it isolated hyperbilirubinemia, or there is isolated elevation of bilirubin while other enzymes are normal. The other group, there is elevation in bilirubin and dearranged other tests within the liver. So, if patient has only the bilirubin is elevated while all other cause tests are normal, we need to ask one simple question. Is the hyperbilirubinemia mainly unconjugated or indirect, or it is mainly conjugated or direct? If the unconjugated process is the defect, so the bilirubin defect nearly before the liver happen. So it is either overproduction of bilirubin, such as occur in hemolytic anemia or ineffective erythropoiesis, or there is intake of bilirubin by hepatocytes, or defect with conjugation of bilirubin by the enzyme responsible for the conjugation, UDPG. So it's usually inherited process, either Gilbert syndrome or Crigler-Najjar syndrome. But if the process mainly conjugated or direct and it is isolated without other defect in enzyme, it is one of two inherited disorder, either Dobbin-Johnson or Rotor syndrome. Other group of patient has elevated bilirubin plus abnormality in the enzymes and liver function tests. These patients should be classified accordingly into hepatocellular or cholestatic. In patients with hepatocellular, the aminotransferase enzyme is highly elevated, while alkaline phosphatase is normal or mildly elevated. This pattern called hepatocellular pattern. While in cholestatic pattern, alkaline phosphatase is highly elevated, while aminotransferase is normal or mildly elevated. So if patient has elevated bilirubin plus abnormality in other liver function tests, we need to know the pattern. Is it hepatocellular or cholestatic? So patient with hepatocellular pattern usually has elevated serum bilirubin, highly elevated aminotransferase enzyme, normal or mildly elevated alkaline phosphatase level. What are the etiologies of hepatocellular pattern? Usually and mainly occur in patients with viral hepatitis, but could occur in other causes like alcoholic liver disease, majority of chronic liver disease and cirrhosis, a lot of drugs and environmental toxin, autoimmune hepatitis, and metabolic disease like Wilson and hemochromatosis. While in cholestatic, there is abnormality interfere with the transport or excretion of bilirubin after conjugation. So there will be, of course, elevated serum bilirubin, highly elevated alkaline phosphatase with mild elevation or normal aminotransferase level. Etiology resulting in cholestatic most commonly due to gallstone or cholelithiasis. Other malignancy causing obstruction to biliary system or lymph node causing obstruction to the biliary system, infiltrative disease, amyloidosis, sarcoidosis, etc. Cholestatic disease of pregnancy, it's common problem occur in second half of pregnancy. Primary biliary cirrhosis or primary biliary cholangitis, drug and toxin, and certain phases of viral hepatitis called cholestatic phase of hepatitis. So, in the end, there are three common patterns of liver disease in general. It can be hemolytic process where there is an increase and conjugated more than conjugated, and the patient has low hemoglobin level and on examination he is pale or anemic. Hepatic, where there is an increased amount of both direct and indirect bilirubin, and ALT, AST, aminotransferase, highly elevated, more than that of alkaline phosphatase. Finally, obstructive type, which elevated bilirubin level mainly conjugated, and there is significant elevation in alkaline phosphatase that is disproportionate to the elevation in AST and ALT. Before we end approach to patient with jaundice, is there any differential diagnosis to the yellowish discoloration of the skin? Yes, there is a certain benign condition, we call it carotenoderma. Carotenoderma, it is a yellowish discoloration of the skin in healthy individual who ingest excessive amount of vegetable and fruits that contain carotene, such as carrots and leafy vegetables. So, in patient complaining of yellowish discoloration of the skin, it is important to differentiate jaundice from carotenoderma. The differentiation is simple. First, jaundice occurs first and mainly in the sclera, while carotenoderma never involves the sclera. It is mainly in the skin and the mucous membrane. This is first. Second, in carotenoderma, the pigmentation usually concentrated on the palm and the sole, forehead and nasolabial, while other parts of the skin is spare. While in patients with jaundice, the discoloration is diffuse all over the body. Finally, history of excessive ingestion of certain vegetable and fruit is suggestive of carotenoderma. Thank you for your listening.